Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling something called a pheochromocytoma. So as always, let's kick it off with our practice question to get things started. A nurse is caring for a client diagnosed with a pheochromocytoma who is scheduled for an adrenalectomy tomorrow morning. Which new prescription should the nurse question? A, we have phenoxybenzamine, 10 milligrams PO twice a day starting today. B, a high sodium diet for the next 24 hours. C, propranolol, 40 milligrams orally twice a day starting tonight. Or D, normal saline infusion at 75 mLs per hour overnight. So think about it. What would be the most concerning? What would you question? And we will circle back to that correct answer at the end of the episode. But first, of course, let's start with our anatomy where everything comes back to. I want you to picture your adrenal glands basically as like little hats that sit on the top of each kidney. Each adrenal gland has two main parts. We've got the cortex on the outside, and then the medulla is the center. The cortex makes things like cortisol and aldosterone, our steroids. And then the medulla, which is going to be our star of the show today, makes our catecholamines. If you remember, these are things like epinephrine and norepinephrine, our classic fight or flight hormones. And because they are fight or flight under normal conditions, the adrenal medulla is releasing those catecholamines in short, controlled little bursts. You get scared, you get startled, you got to run away from a bear, and your sympathetic nervous system's like, yikes, we're under attack, we got to go. Release those catecholamines. Epinephrine makes your heart rate go up. Norepinephrine constricts your blood vessels, so your blood pressure rises. Your pupils dilate so you can see better. Blood is shunting to your muscles so you can run away from said bear. And once you're nice and safe and down, everything settles back down. All right. So what about when things go wrong with a pheochromocytoma? Totally going rogue here. We know we're dealing with a tumor, right? Because we saw that suffix oma, O-M-A, ending in oma. We're dealing with some sort of tumor. A pheochromocytoma is a tumor that develops in the adrenal medulla, that inside part of the adrenal gland, and starts secreting catecholamines just on its own. There's no off switch. There's no, I got away from the bear, I'm good to go. The brain isn't overseeing this. So the tumor just dumps our catecholamines, that epinephrine and norepinephrine, continuously or in sudden intense bursts. So instead of like a brief helpful fight or flight response where we're like, oh my gosh, I got to run away from a bear, now the body just gets hit with surges of these sympathetic stimulation. So we get, heart rate going up. We said that norepinephrine is a vasoconstrictor. It's tightening up those blood vessels. We know when those blood vessels are tighter, we're going to get that high SVR, systemic vascular resistance. And end of the story is our blood pressure is going to spike. The heart's beating faster. It's pushing against that high resistance from that tightened up blood vessels, increased afterload. You've really got hypertension and tachycardia running out of control. And that's going to ultimately hit the whole body. Your metabolism is cranked up, you're sweating a bunch, all those things that you would feel if you are running away from a bear, because that's what these hormones were meant to do in our body. All right. The classic kind of triad of symptoms that your client might express is a pounding headache, because we're getting those vessels constricting, diaphoresis, they're getting really sweaty, and palpitations because of that tachycardia. Okay. And then usually you're going to take your blood pressure and you're like, woo, their blood pressure is off the chart. Also, really key to note, they're usually going to describe this as like a sudden attack. They're laying in bed, they're fine. The pheochromocytoma secretes a bunch of catecholamines, and all of a sudden, their heart feels like it's racing out of their chest. They're drenched in sweat. BP through the roof, horrible headache, etc., etc. Then, things calm down, wears off as the hormones wear off. And when the tumor dumps more hormones, they have another one of these attacks. Now, over time, these repeated surges are putting a massive strain on the cardiovascular system. We've got a consistent high afterload from all that vasoconstriction that can lead to left ventricular hypertrophy because the left ventricle is pumping so darn hard. And eventually that can lead to heart failure. They've got consistent extreme hypertension that's increasing the risk of stroke, retinal damage, damage to the kidneys, basically every tissue in the body because we're blasting it with high pressure. The myocardium itself, that heart muscle, can become stunned from so much catecholamines. They call it catecholamine toxicity. So we can start developing cardiomyopathy and arrhythmias. Even though this tumor in size and in mass is relatively small, the systemic consequences are huge because catecholamines touch every part of our body. And one last key point I'll leave you with here is that these tumors are very sensitive to stimulation. So anything that presses on them, if we get an increase in abdominal pressure, stress, manipulation, that tumor can then boop, dump a ton of catecholamines into the bloodstream. So things like anesthesia induction, certain meds, palpating the abdomen. Whoa, all of a sudden we can see a huge surge in catecholamines that causes the tachycardia, the diaphoresis, the elevated BP, etc. But let's kind of walk it back and talk about a scenario where we see this come to life. Let's do our case study together. You have a 42-year-old man, and he comes in with the worst blood pressure his primary care doctor had ever seen. He had been treated for hypertension for years. Nothing seemed to really do the trick. He was, at least trying to manage it. He was on 3 different antihypertensives, but his blood pressure was still all over the place. So, high 140s, okay, you're kind of fine. We'll keep you where you are. Higher 160s, add another med. And then he went into his provider today and his systolic was 226. Oh my gosh. So crazy hypertensive emergency. He's complaining of sudden episodes where he has a pounding headache, palpitations. He's really, really sweaty, like so sweaty. He's sweating through his clothes and he just feels this sense of impending doom. He says these episodes kind of come and go and he feels, okay between them, maybe a little tired, but the heart fluttering, the headache, the sweatiness, like kind of comes and goes. Okay. So he got sent over to the hospital when he went to his PCP and had that crazy high blood pressure of a systolic in the 220s. His doctor was like, absolutely not. You're at too high of a risk for a stroke or an MI or something. Go to the hospital. We're going to do more of a workup here. So we do labs, we do imaging. We're going to do all of the diagnostics because this picture tells us there is something more than just chronic hypertension going on. All right, so what labs, what diagnostics are we getting here? Well, you'll probably skip right to the imaging and say we need to see those adrenal glands. We need to see if there's a tumor on them. You're absolutely right. Our kind of diagnostic criteria here is going to be a CAT scan, a CT scan, and that will show us the tumor if somebody does have a pheochromocytoma. The blood or urine lab test that you might get is actually just looking at those levels of the catecholamine hormones and their breakdown products. So those are something called metaephrins. So metaephrine, metanorepinephrine, basically the breakdown of that epinephrine, norepinephrine. And we can see that in the blood or urine and see if it is dramatically higher. The problem with this is we know those levels fluctuate dramatically with that dumping of those hormones into the bloodstream. That tumor, that pheochromocytoma is going to dump a bunch of hormone in there We're going to have this attack and then it's going to kind of go away. So just because they have a normal level of those catecholamines does not rule out a pheochromocytoma. With this client's history of chronic hypertension that's all over the place, these attacks, the headache, the sweating, the heart palpitations, this is concerning enough to go ahead and get imaging and see what we see. So the doc orders this. We see he has a pheochromocytoma on the right adrenal gland. He is obviously going to be admitted for this. What is our treatment? We got to get that tumor out of there. We have to actually go in, remove that pheochromocytoma from the adrenal medulla, of course. So, what do we have to do here as the nurse? We need to make him safe before surgery, kind of optimize everything preoperatively, and then we'll take care of him postoperatively too. But first, we are going to do something called an alpha blockade. Basically, we want to kind of shut off those alpha receptors to the norepinephrine that his body is getting massive amounts of, so we don't see that blood pressure go up so much. So we are going to use an alpha adrenergic blocker. This med is called phenoxybenzamine, is most likely what you're going to see used. And again, it's going to go to those alpha receptors. It's basically going to block them off so that all of that extra norepinephrine that the pheochromocytoma is releasing can't cause a massive amount of vasoconstriction and jack up the blood pressure. That's going to help. Again, we're not fixing the problem here, but we're kind of evening things out, making him more stable to get him ready for surgery. Now, you might wonder, if we block those alpha receptors, what about the beta receptors? The beta receptors have more to do with our heart rate. And the next thing we do is go ahead and add a beta blocker to help with the tachycardia. So that's going to be something like propranolol. We are going to help just block some of those beta receptors and slow down that heart rate. It is very important to do the alpha first and then the beta, because if we block the beta receptors first with something like propranolol, we take away the heart's ability to dilate vessels and blunt the catecholamine surge. The alpha receptors are still wide open, so norepinephrine can cause unopposed vasoconstriction and blood pressure will get even higher, potentially, leading to a crisis, a stroke, acute heart failure, etc. So we want to go alpha blocker and then beta blocker. And those are the two big pre-operative nursing interventions that you are going to want to know about for a pheochromocytoma. The rest of it is just really get him to the operating room so that we can remove that tumor. When that tumor is gone, it's not going to be dumping those catecholamines into the blood system, and voila, we have resolved the issue here. Post-operatively, you are going to be watching that blood pressure like a hawk. Most of these clients come back with an arterial line so that we can really closely see it, even minute to minute. Other clinical signs you'll want to monitor for: that headache, chest pain, any neuro changes, any diaphoresis, palpitations, all those things we saw beforehand, preoperatively, that told us he was having a spike in catecholamines, okay? We don't want to jostle him around, reposition really suddenly, sudden or startling noises. Definitely no palpating near the tumor. That is like a really huge nursing care takeaway to think about with pheochromocytomas. No abdominal palpation. We do not want to manipulate and unintentionally cause a dump of those hormones, okay? But post-op, you really keep a super close eye on that blood pressure, and they usually have a pretty smooth recovery because that tumor is gone and we're no longer getting those extra hormones. But with all that being said, it brings us right back to our practice question. Let's review, see now if you can get to that right answer and understand why. So once again, you are caring for a client with a pheochromocytoma. They're scheduled for an adrenalectomy tomorrow morning. What prescription should you question? All right, we had A, the phenoxybenzamine 10 mg orally twice a day starting today. We had B, a high sodium diet. C, propranolol 40 milligrams twice a day starting today. And then D, a normal saline infusion at 75 mils an hour overnight. All right, which of these should we question? And I'll warn you, it's a med that we do eventually give and that we did talk about. See that propranolol. Remember that in pheochromocytoma, catecholamine surges cause intense vasoconstriction, therefore raising the blood pressure, and tachycardia. So we want to block both alpha receptors so we don't get so much squeeze, increasing the blood pressure, and beta receptors so that we slow that heart rate down. But if we give a beta blocker first, like the propranolol, before we block the alpha receptors, you remove the heart's ability to offset that vasoconstriction. And the beta receptors that normally help with vasodilation and rate control are blocked, but the alpha receptors are still fully active. Now, norepinephrine have nothing but that alpha to work with, so we get unopposed vasoconstriction and a dangerous spike in blood pressure. Basically, a lot of words to say if you don't block the alpha receptors first, norepi is going to run out of control and we are going to get a massive hypertensive crisis. So it is correct to give option A, that phenoxybenzamine. We're going to do that first. And it is correct to give C, that propranolol. But the order was written that they're both going to start today, and I should question giving propranolol starting today. I should not be doing that until after we have given that phenoxybenzamine to block those alpha receptors. So I'm definitely going to question C, giving that propranolol today. I'm going to wait, I'm going to hold, I'm going to give that after we block the alpha receptors. And that's really your big key takeaway, along with, I do want to mention one more time, not palpating the abdomen. Remember, our pheochromocytoma is a tumor in the adrenal medulla that sits like a little hat on top of our kidneys. So it's right here in the belly. And if we press on it, we can release more of those catecholamines. No palpating the abdomen. And give that alpha blocker first before you give the beta blocker. That's what you need to know for a pheochromocytoma. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.